You, Vice Chair Cappleman.
Thank you, Chair. Um, this is just amazing. This is very, very exciting for me. I back 33 years ago, I worked at Travelers Immigrants Aid, which is now Heartland Alliance. And I was working my master's in social work, and I did an internship there where I was focusing on providing care to people with who were experiencing mental illness, who were injecting drug users, who had HIV, who were experiencing homelessness. And at least my observation of my clients before I started meeting with them is that none of them were receiving care at mental health clinics. They just weren't going. Their thought was, that's for people with mental illness. It's not for me. Yet they were injecting drug users, self-medicating for their own mental illness. What we found, though, back in the 80s was that they were routinely getting their care at the ERs, or they were getting their care at Cook County Jail. That's where they were getting their care. So I'm a huge fan of FQHCs. My last employment was at Access, an FQHC that provided care for people with mental illness and also provided their health care if they had diabetes or high blood pressure, along those lines. How has the community reacted to these pilots? I'm excited, but how's the community responding?
I think we've gotten really great feedback, and I think during our quality assurance review, Alderman, I think one of the things that's been exciting is starting to hear community members actually requesting our team when they call 911. So you can actually listen to the calls and you can hear people saying, can you please send the care team? So I think that's really what we're looking to build towards, is that residents are aware of this resource and know to ask for it. We're building a lot of relationships with businesses, libraries, settings in the community where we've gotten repeat calls so that they feel like they can use us as a resource. I know our team members have told me that when they're out, even just getting their lunch, people will frequently stop them and inquire about their work and are really glad to know the city is doing this. Glad to know that the city recognizes that incorporating mental health professionals into 911 is something that I think virtually everyone agrees needs to be done. And so I think we've really felt that support from the community.
Yeah, I would just maybe add to that I think in particular, there are business owners who, really feel for these folks, but at the same time, they're, in their store, et cetera, and often pretty dysregulated. And they are very pleased to know that there are resources that are very much focused on getting these people help, and trying to break some of that cycle. And so, even when I hear individual stories, from the teams, et cetera, and, here's an individual, in this coffee shop or this religious setting or that, whatever it might be, that yes, it's about that individual, but it's also the folks who day after day are wanting to, help or at least not hurt further folks who they're interacting with, but have felt that it's been hard to kind of get a mental health professional to them. And they're really excited about the ability to call and actually right then get someone in who knows how to handle the situation. And I don't think we've had no pushback, people are really pleased that we're everywhere. It's is there more of this coming? Can we continue to grow this, et cetera? So certainly, at least to date so far, I would say both among families who we're interacting with, individuals themselves, and then community members, it's been recognition that it's beginning to fill a very much needed gap in Chicago.
Thanks. My biggest complaint was there's just not enough CARES team. But with the CARES team, are we assessing whether or not it's good or not good for a police officer to wear a uniform?
DC or City, do you want to talk about uniforms?
Yeah, I'm actually excited to. I think that's one of the novel things with this particular pilot, which is that we have our officers who are part of this team in a softer look, and it actually is consistent, I think, with the team look. Right, we have a polo shirt, which is softer. Still able to identify, have name and all the identifiers so that they do know who they're interacting with as the officers identify themselves. I think that soft look is actually one of the most important things about this, because we do understand that a uniform can mean many things to people, and we're there to provide the support that's necessary for our team members to do what we believe is most appropriate for that call.
Makes sense. All right, thanks. The Uptown community, we have the highest rate of people living with mental illness than any other community in the United States. I'm thinking about probably about 6-7 years ago, I came across a woman at the corner of Broadway Wilson. She said, you know what, I'm feeling a little dizzy right now. I think I'll call 911. And she did. And EMT came, a fire truck came, and a police car arrived. And the EMT came out and said, hi, said her name. They knew her well. And they got the gurney out. She strapped herself, gave a thumbs up. It's time to go. And I was questioning EMT and said, you know, she can ambulate to the Weiss Hospital. I'll just escort her there for, 3 blocks over there. He said, no, we're afraid of a lawsuit. We'll go ahead and do this. And then after she was inside the ambulance, the EMT said, I got news for you, Alderman. We do this for this person twice a day, and we've been doing that for the past 2 years. Her care alone is costing close to $1 million, and that's just for ambulance transport and the ER workup. In this model that we have, she did not report that she had a mental health crisis, but do we have a system in place to identify these overusers of 911 so that we can look at what the other details? She really just wanted a sandwich.
Yeah. And I think, as someone who's worked in emergency departments, like we see this. This is where, there's been work around who are high utilizers, right, in our system across CFD and et cetera. Because CFD provides all of the 911 response here, you actually have a, universe that you can assess some of that. And, we're having, these high utilizers sort of weekly meetings. Where does this come in? Like wanting to pull more of that direct, when we talk about outreach, right? It's also about where people aren't calling, but we know that they're the highest utilizers. There's a lot of support across the entire medical establishment to try to decrease, of course, emergency department visits for folks, whether that's medical, physical or mental health. We've been looking at some of this, but again, there's protocols, pieces that come in.
I think things I would add, Alderman, is that one thing we're doing data work right now to generate high utilizer lists so that we can do proactive outreach to those folks to try to engage them before the next crisis or emergency. So we're actually working on those lists right now. A second thing is we have a complex case team meeting every week now where we case conference on complex cases, and those referrals come from our data. They also come frequently from city council members, from sister agencies, from community, organizations. Features of those calls or those cases are frequently individuals who are living with serious mental illness, often co-occurring substance use, not on medication. There's high rates of anosognosia. So the patient does not believe they're ill, even though they're demonstrating very clear signs and symptoms that they are, very frequently unsheltered. So you have to really have a very tight strategy about how to best work on those cases. And then the third thing I would say is diversion. We really want to move away from diverting people to EDs when they don't need to be in an ED. And so this is why, with our ARPA funds, which we're grateful to you and your colleagues for having approved, is we're or standing up a high utilizer stabilization housing model. So we could literally direct, if that patient you referenced, Alderman, was medically stable, or once we established that they were medically stable, there's a universe in which we would begin to consider diverting them directly into stabilization housing, where they would get primary care, SUD care, and site care in their own unit to help them achieve stability, so we can link them into permanent supportive housing. And that is the direction we think we need to go for those patients. We need to have a diversionary housing option.
That's powerful, because this woman was experiencing homelessness, had bipolar, is a crack addict. We would save money by housing her at the Drake Hotel with room service. This is music to my ears. I know of individuals with frequent arrests for their violent behavior. It's often related to their drug use because they're self-medicating for their mental illness. And when they go before the judge, they're frequently offered drug treatment. Oftentimes first choice is inpatient, and if they refuse that, they're offered outpatient. And if they refuse that, which I'm hearing from the Cook County State's Attorney's Office, that is the norm. That frequently happens, then they go to Cook County Jail, where they also refuse treatment there. Do we have any data yet, I'm anxious, that shows that the CARES team model motivates people to accept drug treatment, which I believe would drastically reduce recidivism?
You want to start with care, and then I'll chime in?
Yeah, so we do KJ assessments in the field for substance use screening, and we do use motivational interviewing strategies. I don't think at this point, Alderman, we have enough longitudinal data that I could tell you that we're seeing patterns of service refusal turn into patterns of service engagement. We will have to have longitudinal data to do that. But I think your observation is right on, that service refusal for patients with more complex behavioral health conditions is the norm. So whenever we're setting up systems that assume that it's not going to be a big challenge, you are starting from the wrong assumption. That part of complex behavioral health conditions is really working through ambivalence and working through even perhaps believing that one does not have an illness. And I know you know that from having done the work you do. It's not good enough to just say, oh, would you like services today? No, okay, well, have a nice day. That's not robust enough, because we know when you do that, patients with the most complex conditions die 20 to 25 years earlier than everyone else. And it's because most of the patients with complex behavioral health conditions, almost a majority, are not in treatment.
And I would just maybe chime in, to this point, it's a little bit aside from care, but some of the diversion work that we've been partnering with CPD on around this, we're really excited about. It's about, when folks are arrested early, right? Like before they've been in lots and lots of times, possessions, et cetera, and they are offered the opportunity to divert to substance use treatment right then, like not even get booked, not even go. And, DC or city, I don't know if you want to chime in, but we started with a pilot with that at CPD. It's now expanded, across all of the districts. And as public health folks, there's nothing we like better than getting folks into that treatment early, breaking that, helping to avoid the criminal justice system where we can. And so we think, this crisis response piece is a part of it, but it goes along with the diversion work we're doing, and CPD has been a really good partner on that.
Thanks. As a social worker, I learned you don't just fix the problem, you fix the system that perpetuates the problem. And I'm a huge fan of Malcolm Gladwell, author of The Tipping Point. He's done some great work on addressing chronic homelessness. And he talked about the need to address the outliers. And I can think of one outlier in my community who was kicked out of a supportive housing. So he was running the train for 18 months. And then someone took him to Uptown because they said this is a place to get services. He had gangrene and in his foot. And Matt, you know him well. He was later in a wheelchair. People were giving him things, so he was protecting all his belongings. So he couldn't leave because of all his belongings. And then he couldn't leave because he had bed bugs. And then he couldn't leave because he was in a wheelchair and the place couldn't take him because he was wheelchair bound. And then they couldn't take him because refusing all help. So he was one of those outliers. And Malcolm Gladwell suggests that if we focus on all the obstacles in place of those outliers, we can learn a lot, and we can use that same information to help others who are not among those outliers. So is the CARES team, when they interact with these people, these outliers, are they providing feedback to DFSS and CDPH about those roadblocks that these people experience so that we can do a better job of addressing chronic homelessness?
Yes, I love that point. I think that looking to outliers to really guide us on how to change systems, I could not agree with you more about that point. And I've worked with you and some of your colleagues on outlier cases. And I'll give you some examples of things we've changed because of the outlier cases. So one of them was we knew we needed to have diversionary housing because there was no single system that was willing to accommodate some of the outlier cases. So the EDs won't take the patient because the patient doesn't meet criteria for inpatient admission. So they'll give the patient maybe oral medication that a patient who's homeless and maybe has cognitive difficulties related to an untreated mental illness, they're not going to remember their meds. But then if you take the patient to a shelter, the patient perhaps has an open wound or is not ambulatory, so they can't stay there, right? So there in a number of these outlier cases, there was no single setting that was willing to meet the patient where they were. And so they just end up right back out on the street. And I know you're very familiar with these cases. So that's where we said what we need to have is actually a diversionary housing option where the patient can go and we can actually address the medical piece, the psychiatry piece, and the SUD piece, plus the housing piece. And it's very low barrier. So we don't have all the restrictions that some of those other settings have. The complex case team was created in response to outliers, because what we saw with outliers is if you just send a response team out, but you don't have a plan, you're just going to end up taking them to the nearest ED and we're going to do the whole thing over again. So what we've learned with complex case planning, you actually need to plan your transport strategy in advance. You need to actually decide, okay, where can we take this patient if they're willing to go? Okay, they're willing to go to the ED. They have belongings, so we need to figure out where we're going to put their belongings. Like we have to do all that planning before we get there. And so that grew out of those cases. So I think your point is very well taken, that we're trying to be guided by outliers because they teach us how to do better.
Wow. I'll close with this. I am passionate about mental health care, and I've been very vocal about my dad with his bipolar that ended with his suicide. And I have been frustrated so many times, so many decades about the way we respond to the needs of people with mental illness. And for the very first time, I have real hope. I'm just very pleased. Dr. Artie, your focus on the use of evidence-based best practices, you're data-driven. This is what we need. So thank you so much. And I know there's so much more to come. Thank you. Thank you, Chairman.